Welcome, everybody. We're going to give it a minute or so for everybody to get in. Amy, I can't see if I can see from up here. Okay.
Hi.
Yeah, so we still have people joining, so we're just going to give it another minute or so. Since you guys were in the waiting room, it can take a minute for everybody to get in. All right. We have a great talk with Dr. Ann O'Donnell, and we'll get started with the introductions so she can discuss this very important topic with us. Bronchiectasis Diagnostics, what to know about PFTs, imaging, and sputum cultures. My name is Mary Rose Kitlowski, and I am the founder and president of Running on Air. If you haven't heard of us before, our mission is to help others breathe more easily through access to oxygen appropriate to their needs. Our focus is on advocating, informing, and reforming through raising awareness, promoting policy changes, and educating patients and providers about supplemental oxygen and lung diseases, especially primary ciliary dyskinesia and bronchiectasis. We run hard so others can breathe easy. There are our social media links on the right if you want to follow us. One of the things we are very happy to provide for supplemental oxygen users is a comparison chart of the devices, the POCs that are available within the US. And this is available on our website with a lot of other information. I am very happy to be co-moderating with Amy Lietman, who is the president of NTM Info and Research. Amy and I do a lot of these bronchiectasis webinars together, and we're very happy to bring these to the community. And I will turn it over to Amy.
Thank you, everybody. We're very happy to have you here today. Thank you, Mary. It's wonderful to co-host yet another webinar. I'm the president of NTM Info and Research. We are the patient advocacy group for nontuberculous mycobacterial disease and bronchiectasis and other comorbidities. We have a whole support group network, which if you are looking for support as a patient or caregiver, I hope you'll log on to ntminfo.org, find out more information. A lot of the groups are online. We have groups for under 50. We have a men's group forming. We have a group in Espanol. We have an international group as well. And we have actually several international groups. So we hope you'll find us and join us. We also have an online forum, NTMBE Connect. Please join us online. It's a really great, robust forum. We have a wonderful YouTube channel, over 120 videos, including past conference sessions and webinars. And you can also find and download copies of our pamphlet, Insight, A Patient's Perspective, which is a very comprehensive guide to NTM lung disease. You can also request copies from our website. We hand them out for free. So again, that's ntminfo.org, and you can find patient support and help and information online. Also, save the date. Monday, August 4th is World NTM Awareness Day. Every year around the world, we aim to raise awareness of NTM lung disease. The actual date of World NTM Awareness is August 4th, but we will be celebrating all month long. We will be bringing you a whole host of webinars that month. There will be also social media campaigns that you can also share, so you can help raise awareness as well. So again, please log on to ntminfo.org, and you can also log on to worldntmday.org for more information.
Want to add here that one of the things Running on Air does throughout August is we have a daily fact about NTM. So it's a good way to help educate people around you by sharing those on social media. We want to thank Insmed, who is supporting, sponsoring this webinar today. And a few housekeeping things. So this webinar is being recorded. You should have heard that when you logged in. The recording will be emailed once it is online. You can put your questions in the Q&A. I'm not sure that the chat is available, but if you put your questions in the chat, we will probably not see them. So put them in the Q&A. And then Dr. O'Donnell cannot give personal medical advice. So when you ask your questions, please make them general. Yeah, she can't give personal medical advice in this webinar. And on to our speaker. So Dr. O'Donnell has been my pulmonologist for close to at least 25 years, if not 30 or more. So she is professor of medicine at Georgetown University and chief of the Division of Pulmonary Critical Care and Sleep Medicine at MedStar Georgetown University Hospital, as well as the Nehemiah and Naomi Cohen Chair in the Pulmonary Disease Research. Having authored over 40 manuscripts, Dr. O'Donnell is an internationally recognized expert in bronchiectasis and respiratory infections. She has been a principal investigator on numerous clinical trials, investigating new therapies for bronchiectasis and NTM infections. And I'm also happy to say that I have been in some of those trials. So thank you very much, Dr. O'Donnell.
Great. Thank you, Mary, and also Amy, for inviting me to do this. Everything good with my sound?
Yep.
Yeah. Okay, great. So, and I'm just like amazed that there's 303 participants right now. Fantastic to NTMIR, to Running on Air, to all of Amy and Mary's efforts to organize this wonderful group. And hopefully I can do you justice with my little talk here. I was asked to talk about some basic testing in bronchiectasis, and that's what I'm going to do. I'm going to throw in a few other items, and then there'll be plenty of time for Mary's going to moderate the Q&A, I think, Greg, correct?
Yeah, Amy and I will.
Okay, perfect. Okay, so let me share my screen here. Okay. It's good. Okay.
Yep.
So,
you're up.
yeah, thank you. So as Mary said, I'm from Georgetown University in Washington, D.C., and I've been involved in helping patients with this disease for many, many years. So again, really happy to be here. I do want to say I do a number of clinical trials and consulting for pharmaceutical and other companies and foundations that are interested in this disease. I also want to stress, although I'm not really going to talk about treatments very much today, that as of right now, there's no FDA approved treatments. So, everything I talk about treatment wise will be, as we say, off label. Insmed is sponsoring this, but I'm not receiving any compensation from Insmed or this talk is not really about Insmed related items. So, when I see patients, especially patients for the first time, I think that there's three big questions that patients have, right? And of course, the first thing is, this big long word, bronchiectasis. It's not something that you hear people talking about. Your family doesn't know what it is. It's not the easiest word to pronounce. So I think, a big part of talking about bronchiectasis is just understanding what it is. And basically, it's an anatomic abnormality in the airways of the lungs. And I'm going to show you some imaging and some other images that sort of help to explain that. So the bronchiectasis is the actual damage of your airways that allows infections to occur. The second thing is like, why do I have this, right? And that's a challenging question, because there are many reasons why people get bronchiectasis. And unfortunately, even when we look really hard for the actual etiology of your bronchiectasis, we don't always discover reasons. So about 20 to 30% of patients worldwide with bronchiectasis are what we call idiopathic bronchiectasis, because we're kind of idiots and we don't know the cause. But about 80% or 70 to 80% of the time, we can figure out a reason why you have the disease. And then the other thing is, what's going to happen to me with this disease? And I again want to stress that the bronchiectasis is the anatomic problem in your lungs with your airways. And the complications of those problems are infections, like routine bacterial infections, non-tuberculous mycobacterial infections, fungal infections, viral infections. Other complications that patients have with this, it's not uncommon, and I'm sure many of you have experienced bleeding from your lungs, what we call hemoptysis, which is because those damaged airways are irritated, particularly if they're infected, and that irritation brings more blood flow to those areas, and that's why you cough up blood. And the other complication is, like, once it starts, there's this vicious cycle or vicious vortex that I'll explain a little bit more in a minute, that we really want to understand well, because if we let the vortex just continue, the disease will get worse, more areas of your lung will get damaged, and all of our treatments and really all of our evaluation is aimed at understanding this vicious vortex. So just a quick overview of the disease in the US. There's probably at least 500 to 600,000 US people living in the US who have bronchiectasis. We really don't have a firm number because it's not a reportable disease. It's not like we tell the public health departments that you have this. So that's probably something of an underestimate. We do know about 2/3 of patients with bronchiectasis are women, and about 3/4 of patients are 65 years or older. We also know that this disease, which was once thought to be like kind of a disease that we wouldn't see anymore, back in the 60s, 70s, once antibiotics came along to treat infections, this disease is actually, since 2000, has been rising in incidence and prevalence. And of course, that's why there's so many people attending this meeting today. We also know that there's a lot of what we would consider to be silent bronchiectasis out there. And recently, a large group of patients who were screened in New York for lung cancer. So they had low-dose CT screening because they had a history of smoking. The scans were not done because of bronchiectasis symptoms, but they were simply done to screen the patient for lung cancer. And almost 25% of those patients had some sign of bronchiectasis on their CT. But, bronchiectasis is still a rare disease. For every one patient in the US with bronchiectasis, there's about 20 patients who have COPD. So COPD, asthma are much more common than bronchiectasis. But also a comparison is that, the classic bronchiectasis disease is cystic fibrosis, and only about 35,000 people, so 1/10 of the number of patients with non-cystic fibrosis bronchiectasis compared to CF. And just again, to touch on this issue of why patients get bronchiectasis, this is a large database. It's from Europe, but it really is consistent with the findings in the US. The big blue part of the pie is the idiopathic part, so a significant number of patients who we don't discover a cause. The red is the patient had an infection, it damaged their airways, and that's why they have bronchiectasis. And then the less common things in the smaller slices. In the US, in our database that I'm sure many of you are part of, the US Bronchiectasis and NTM Research Registry, a large number of patients with the diagnosis of bronchiectasis had a previous pneumonia, which may or may not have scarred the lungs and resulted in the bronchiectasis. About 20% of patients with bronchiectasis actually have COPD, so the smoking, tobacco-related disease of COPD. About 20 to 30% also have asthma. Sometimes the asthma is the cause of the bronchiectasis. Sometimes the bronchiectasis is actually more of a complication of the asthma. A significant amount of patients in our registry have underlying reflux disease. Now, the question is it cause and effect, or is it just two things existing in the same patient? And then there's other less common reasons to get bronchiectasis, like autoimmune diseases like rheumatoid arthritis or Sjogren's, gastrointestinal autoimmune diseases like Crohn's or ulcerative colitis. About 5% of patients in our registry have an immune deficiency, so immunoglobulins are low, and that's why they get these infections that lead to the bronchiectasis. A much more rare disease, but obviously well represented in our patient population, is primary ciliary dyskinesia, sometimes called Cartaginer syndrome, and then prior tuberculosis. So there's a lot of reasons, as you can see again here on the EMBARC data, that patients get bronchiectasis. Now, I'm going to go through here really the highlights of how your physician or your clinician should approach you once you are the diagnosis of bronchiectasis is made. And right now, there's 3 large guidelines that help us clinicians evaluate the patients. These guidelines are made by consensus of experts. And so there's one from the British Thoracic Society, there's one from the European Respiratory Society, and a third from the Spanish Respiratory Society. And they're all pretty much in agreement that every patient with bronchiectasis, obviously has to have a CT scan to prove that that they have the disease. And then this type of testing is recommended. So everyone should get a blood count, should get their immunoglobulins checked. That's the IgG, IgA, IgM. 2 of the guidelines recommend that you be checked for a relatively rare complication of asthma, which is called allergic bronchopulmonary aspergillosis. All of the guidelines strongly recommend the routine culturing of your sputum or your respiratory secretions. And then at least 2 of the guidelines recommend lung testing, lung function testing. So I'm going to talk today about imaging. I'm going to talk about sputum and culturing, and then I'm going to conclude with pulmonary function tests and why we do those in this disease. So like I said, the imaging, the simple imaging is a chest x-ray. Unfortunately, bronchiectasis is often missed on a chest x-ray. So high resolution chest CT without contrast is the gold standard for diagnosing bronchiectasis. And I'm sure most, if not all of you on the call have had that study, because that's how we make the diagnosis. And then, like I said, I'm going to talk about respiratory cultures and about pulmonary function testing. I already mentioned doing some just routine blood work and assessing for underlying disease. So just to get your anatomy covered here, I know some of my patients are on this webinar, and you've heard me say your lungs like a sponge with a series of pipes inside. It's actually like a upside down tree trunk, right? Your bronchial tubes. You have your main trachea, you have your large trachea, right, that starts right under your vocal cords. It breaks into the 2 main bronchial tubes in each lung. And then, as you can see, just like tree branches, those bronchi become smaller and thinner as they get out towards the surface of the lung. And ultimately, you go from the large trachea, main bronchi, smaller bronchi, into the air sacs or alveoli, where the actual exchange of oxygen hitting the blood and the blood absorbing the oxygen takes place. So that's how the lungs, that's the anatomy of the lungs, and that's how they take the oxygen in and distribute it to the bloodstream. In bronchiectasis, those airways are damaged. Instead of tapering smaller and smaller as they get towards the edges of your lung, they stay big and they stay thick-walled, and that's why they retain mucus. So I put this in here again to, emphasize that CT scan is really like the key first step in this diagnosis. When you slide through the CT scan, you generally, with chest CT images, you're going to have your arms above your head so that the lungs are in full view. This gives us this two-dimensional picture of your lungs, which is just so much more detailed than the chest X-ray. And again, another thing I tell patients all the time is this idea that you're like a loaf of bread being sliced up on a slicing machine, and then we look at each slice. And this little visual here kind of shows you what I mean. And then down here on the left, right, again, it's a front to back slice that we take through the lungs, and it just gives us all this detail that we can see. And then the radiologist can actually do fancy things with the CT computer to kind of, put things in different directions, kind of take in these pink ones down in the bottom. They can like take the lung spongy part out of the picture and just focus on your airways. The CT is like so important. I can't say that enough. And I really expect my patients to, want me to show you your CT. Because in my mind, like the CT images are, pictures 1,000 words kind of thing, because it really helps, I think, patients to understand exactly what's going on in their lungs and also why we propose certain therapies. So in this scan, first I'm going to go through the picture up on top, right? Again, I've showed you the main trachea, the bronchi, and then, going down into the smaller. And here in the left lower lobe, is where the bronchiectasis is in this image. And again, this is to talk about the vicious cycle or the vicious vortex, where there's an initial damage to your lungs. That damage results in these airways that are dilated. And that's what this is on these CT slices. The airways become more thick-walled, they enlarge. The mucus that is normal, we all have mucus in our lungs, but when those airways are saggy like that, if you will, the normal mucus just pools in those parts of the airway, and that's a fertile ground for infection. So airway damage, the mucus is abnormally stuck down there, it's hard to clear. That results in bacterial colonization, and that brings neutrophil inflammation or eosinophilic inflammation into the lungs. And then you get this cycle or circle or vortex that continues. Some of the other features that we see, again, this is an example of bronchiectasis where the wall of the bronchial tube is thick and the airway itself is much bigger than the blood vessel that's right next to it. And then this picture on the right shows in the lower parts of the lung, the heart is here in the front. So in the lower parts of the lung, there's a lot of mucus accumulated, right? The lung should look nice and black like this. But in this image here, you can see how mucus is, that white stuff is mucus, is stuck in those airways. And then there's a little cavity because the lung has been hollowed out by the infection. Sometimes we have what we call cystic bronchiectasis. And these two images here are an example of where the left lower lobe here is, instead of looking nice and black with just little squiggly blood vessels through it, you can see how damaged it is, how, these are like big cysts and, really don't provide any function to the lung. And you can see that also here in the left upper lobe on these slices. So a big difference between your normal lung and your damaged lung. And again, I can't stress enough how I think looking at your images with your physician or your clinician really helps you to get an understanding of what's going on in your lungs. And, I don't want to gross anybody out, but I want to show you how good CT is. This is a lung that's been removed in transplant patient had their lung removed because they were getting a new lung for transplant. And you can see it really lines up here. Like this is the airways that are thicker and bigger and yellow because they're filled with pus. And because these airways are, and the surrounding lung is inflamed, you can see these extra large blood vessels here. And that's why often you have, you cough up blood. And we really see this on the CT. I mean, again, I'm obviously look at these all the time, but I think everyone can appreciate how there's little thickened walled airways and how the white stuff of mucus is stuck in these airways, just like it is when we slice up the lung that's removed for transplant. So, it's real important to do that. Now, I know many of you look at your radiology reports, and sometimes the radiologist uses this weird terminology of tree in bud nodularity. And over the years, I've tried to acquire some photos that show a tree in bud. But again, it's that idea of the tree branch, right, with the budding smaller branches that end in these saccular looking buds, right? And we see that on these images here, where you go from the larger airway that looks pretty normal, and then it branches out, and then at the end of that branch, like here also, is a wad of mucus, and that's the bud. Now, when radiologists often use this terminology, and sometimes they also, and those who, you read your scans and they're like, it says, oh, this is, consistent with mycobacterial infection. The truth is, radiologists can't diagnose the infection. They diagnose the bronchiectasis, but the only way you're going to know what the infection is to have a culture of the mucus. So I can't
Dr. O'Donnell?
Yeah.
I just want to let you know that there's a little bit of a delay between your slides coming up.
Okay. Is that
so? Yeah, it's
Sorry.
been okay for me, but you're circling things on the old slide to what I'm seeing. So when the new
sorry.
slide comes up, I see what you're talking about. But I just wanted to let you know that maybe,
I won't
pause for a
circle anymore.
moment or something.
Okay.
Yeah,
Sorry about
I know
that.
you can't tell when we see it, but I just wanted to let you know that.
Okay, I apologize about that. All right. Mhm. All right. Wow. Can you see this slide now?
The one that I'm seeing right now is the CT scans, the tree and bud.
Yeah, I don't know why there's a delay.
Okay, the new one just came up.
All right, I'll just talk a little slower, I guess. Again, just another pictorial here that shows you the vicious cycle, the vicious vortex on the right. Let me get that thing out of the way. And the retention of mucus in these airways. And again, that's reflected on your CT images. All right. I'm going to move now from the CT part of things and the imaging into talking about why we do cultures and how we do cultures and the importance of cultures in managing this disease. And I'm hoping this slide is displayed now.
It is.
Okay, which talks about the common bacteria that we see in patients with bronchiectasis. And I'm using this slide to make another key point, which is it's really important for patients to know what bacteria they generally have in their culture, and the importance of giving or having what we call surveillance cultures, so that we can monitor any changes in what bacteria are there in your airways over time. Another thing that has sort of been resurrected is this idea of a sputum color chart. And, I do want to say that this is something that I think patients should understand. I think most patients do, that when your sputum is kind of gray and just mucousy, that generally is kind of how it should be in bronchiectasis. But as it becomes more colorful, more dark, more yellow, more green, or more bloody, we use these words like mucoid, as you can see on that that color chart there, mucoid, then mucopurulent, then purulent, and purulent, right? Green, dark, yellow. And, why do we, use something as simple as this? It turns out it actually does fairly well correlate with the bacteria that you have. So the darker, greener, more pussy your mucus is, the more likely you'll have Pseudomonas, which is illustrated here in the green. So again, this is like one of those things, the visual that can help you to determine a little bit about, again, it's not the definitive thing is the culture, but it gives you a little bit of clue as to what might be going on in terms of the microbiology down in your lungs. I'm gonna pause a second here. I know, of course, many of you don't produce a lot of sputum, are more of a dry bronchiectasis. And we often see that when your bronchiectasis is more out toward the edges of your lung, when you have that kind of tree and bud finding on the CT. And, again, that sometimes goes along with, instead of having regular bacteria in your culture, that you have possibly have the non-tuberculous mycobacterium. Now, how do we go after obtaining sputum, right? We like very much the idea of you just coughing it up and allowing us to send it to the lab. Sometimes we have to resort to using nebulized treatment, like a saline treatment, what we call a sputum induction, in order to get a sample. And, sometimes we have to resort to bronchoscopy. We actually much prefer that we get the sputum from you spontaneously or induced, rather than to put you through the procedure of bronchoscopy. One thing about bronchoscopy, of course, it's a day out of your life. It's sedation or anesthesia, and it actually can somewhat dilute the findings of cultures in your lungs. So we try to make our best efforts here to get patients to cough it up. And, sometimes we use our other tools, right? I mentioned using nebulized saline. We often hook that nebulizer up to the Aerobica device, which is a flutter device to help you produce the sputum. At home, you can obviously do that also to get a sputum sample. Use your nebulizer. If you're using the Aerobica or the Acapella device, that will help. If you use a vest, that will often help you to produce sputum. And we see Mary here running. So exercise, yoga, things like that will also aid in sputum production. Now I have a little video here. Hopefully this is gonna work with this delay. I grabbed a couple of videos off YouTube. This is another way. This is an airway clearance technique that we use therapeutically, but it's also a way to help with obtaining a sputum specimen.
Huff coughing is an efficient way of getting mucus out of your lungs, especially from deep in your lungs where mucus can settle in the lower parts. Huff coughing can be done in 4 easy steps. The first step is to take a big belly breath in. You can do this by putting your hand on your belly. As you take a breath in, you should see your hand move away from your body. Great. The second step is to hold your breath for 3 seconds. The third step is that you're going to keep your mouth in the shape of an O. If you have a hard time doing that, you can use the tubing to help keep your mouth in the O shape. The last step is to exhale like you're fogging up a mirror until all of the air is out of your lungs. Let's try.
Yeah, so sometimes that technique, which again we often recommend for therapeutic purposes, right, to help, will also get you to produce a specimen. So very simply, I know patients know this. You collect the sputum in a sterile container, which usually is like a cup used for urine cultures. You can refrigerate the specimen overnight if you can't get it to the lab right away. Once the lab gets it, we generally are asking them to do, from the one specimen, we ask them to do the 3 types of cultures, including a routine bacterial culture, what we call a mycobacterial or acid-fast culture, and a fungal culture. Sometimes your physician or your clinician may ask you to be assessed for viruses. And of course, we're all familiar with this now from COVID, that a viral investigation is generally a nasal swab, occasionally a swab of your respiratory secretions to be specifically tested for viruses. And again, once the lab gets the specimen, they process it in a way that allows them to initially look at the specimen right under the microscope. Then they put it onto a culture plate that you see there in the middle. The culture plate grows something, and then they analyze it in a highly technological system that can identify the specific bacterias. The next step is, once the lab has identified what the bacteria or the organism is, then they can do what we call susceptibility testing. And that's in that in the middle on the bottom, where little discs of antibiotics are placed on the bacteria. And if there's killing of those bacterial colonies around that disc, then we know that antibiotic is going to work against that particular bacteria. Now, that's kind of the basic susceptibility testing. It's become much more sophisticated over the years, but it is an important part of what the micro lab tells us about your organisms. So just to set expectations, when you submit a culture, we get the results of the routine culture in about 3 to 5 days. I'm sure you all know that if we are looking for mycobacterium, that immediate result is a smear, but it takes 1 to 6 weeks for the organism to actually grow in the lab. And fungal cultures, also we can get somewhat of an immediate result, but it actually takes 1 to 3 weeks for the lab to give us a final answer. And just, with these are the reports, I know you all scour your LabCorp portals and other portals. And, these things, it's fantastic that patients are able to look at this. Sometimes patients are seeing it before I do. But they can be difficult to interpret. And I want you not to go to Dr. Google and with the word Pseudomonas, because, your head will swim at all the things that it says. But it's great that patients are able to see this and really keep on top of the organism that they have. And then the interpretation of the susceptibility can be somewhat confusing. This is how the report comes out. S means it's susceptible. I means it's maybe, and R is resistant. But there's a complexity to understanding the susceptibility, particularly in organisms like MAC, that we want to avoid over interpreting. Yeah, and then the cultures that are done for looking for the mycobacterium give us different results. They talk about the smear, they talk about what the results of the culture is, which again takes several weeks, and then they give us the information about the antibiotic susceptibility. So just to conclude on the issue of your sputums, I can't stress enough how important the sputum collection is. And if you can't do the, expectorate it spontaneously, you should really do your best to do a method of induction in order to collect sputum, because it's really vitally important to taking care of you. And, and should be done routinely almost every time you see your physician. And just finally, why do we do pulmonary function testing in this disease? Really, it's to assess your lung capacity, your ability to transfer oxygen, through your lungs to your bloodstream. There's value in knowing, when you're first diagnosed, and then serial measurements over time in order to assess your disease status and whether you're getting worse. So, the typical pulmonary function test, you sit in the box, you're instructed by the respiratory therapist in different maneuvers, and we get measurements of your lung capacity. Another test that some patients have is what we call a 6-minute walk. And the 6-minute walk is a measurement of your functional capability and your oxygen level. So for patients who have more advanced disease based on their regular pulmonary function, we'll do a 6-minute walk to see how, what their exercise tolerance is and whether you need to use supplemental oxygen. I'm going to skip over this, but, this is just what the pulmonary function booth looks like. I'm sure most of you have had this test, and, the result that we get is what we call spirometry and then some other testing. It really helps us to tell how open your airways are. And again, the importance of this is to assess your functional status, but probably even more important is to monitor this serially so that we can see, how well or how not well things are going with the treatments that we recommend. So another question, just to close this talk is, what's the cadence of doing these tests? How often should you have these tests when you're being monitored by your physician? And of course, probably the biggest question is how safe and is CT scanning, and how often should it be done? So CT scanning nowadays is almost universally low dose radiation exposure. It's much more than a chest X-ray. It's somewhat more than flying across country in an airplane, but it's so important to monitoring of the disease that we really have to accept that this is something that needs to be done fairly routinely. It really depends upon your baseline disease and how often you get sick, how often you need this. If you're really stable, a scan at baseline and every 2 years, 4 years is reasonable. But if you have more active symptoms, the scan needs to be done more frequently. In terms of the sputum collection, I love sputum. I love sending it to the lab. All of my patients know how well the lab can mess it up in terms of losing it or mislabeling it or not running the test. But sputum, is a fairly easy commodity for many of our patients. So I definitely advocate and want you to understand that I think there's great importance to routine surveillance. The cultures change over time. Some patients will have, consistent, say, Pseudomonas bacteria, and then MAC will show up. So it's very important to have a routine with your physician as to how often you're going to collect sputums. I think there's some reticence in the wider world, in the physician offices about sputum, but there shouldn't be. It's not contagious unless you're talking about tuberculosis. And if there is that reticence, it certainly can be done at home, and you can bring it to the lab, as I mentioned before. In terms of how frequently to do pulmonary function testing, again, generally that's yearly, but it really depends upon how your disease is progressing or hopefully not progressing. So I'm going to just conclude, and I'm sorry about this slide delay thing, but yeah, I'm sorry. I'm really sorry that happened, but want to go back to the idea that this is a complex disease. Each patient is their own individual patient. There's no one right way of testing that encompasses all patients, but you should be approached in a structured manner. Obviously, you need the CT to prove that you have the disease. You need the sputum cultures to see what your infections are, if any, and you need the pulmonary function tests to see how your lungs are doing with the disease and whether you're progressing. And all of this feeds back to this idea of really addressing all aspects of the vicious cycle, vicious vortex, to get the best possible outcome with your disease. I just want to say one word about exacerbations. I think this is another key education point for patients and for physicians who care for patients with bronchiectasis. You really have to have a definition of what an exacerbation is in mind. You as a patient should know, hey, I'm having signs that suggest to me that I might be getting sick. I might be having a flare-up or what we call an exacerbation. And generally those signs are what I have listed here, that your cough changes, your sputum volume or the consistency of your sputum changes, sputum gets more dark, purulent, you're more breathless, you're more fatigued, or you're having hemoptysis. And we have this sort of accepted definition that if you have 3 or more of those symptoms that last for at least 48 hours, that's really the time you need to contact your healthcare provider in order to assess whether this is an exacerbation and whether you need some step up in treatment. Because exacerbations are bad and they take the toll on you, and we want to nip them in the bud, and we want to decrease them as you get your care over time. So to conclude, I want to again thank Amy and Mary and the organizations. I thank you all for attending. I just want to leave you with again a recap that imaging is super important, that you need to have a basic grasp on what your imaging shows. You want to understand what areas of your lung are the most involved so you can sort of assess a treatment plan for that. You want to know your bug because you know, you want to have a sense of what bacteria you have and what antibiotics are good for you, so that you're not given the wrong antibiotic. And you need the PFTs to help with your prognosis. So I am now going to close off these slides, and we'll take the questions.
Okay, great. Thank you. We have a lot of pre-submitted questions and a lot of questions online. So I will kick it off with one of the questions that was previously submitted, because I think this goes nicely right into where we were talking about, you know, imaging and what it shows. So somebody has asked, does MAC ever clear up in the lungs and show a clear CT, or will a CT scan always show evidence of it, of tree and bud or scarring, even when sputum cultures are negative?
Yes, that's a great question. I mean, it really is 2 separate diseases, right? There's the bronchiectasis, which is the scar, the airway damage. And then the MAC is the bacteria that, you know, one of the bacteria that can make that damage worse. So yes, you can, you know, in general, if we treat the MAC with the antibiotics, the culture's clear, the bronchiectasis is still going to be there. Now, it can get better, but generally you're always, once you have the bronchiectasis, the damaged airways, you're going to have those, but you can clear the infections, you know, with caveats there. But yes, the 2 things are connected, but they're not one and one is not 2 there.
Okay.
I just want to let everybody know, there's been a question or two. This webinar is being recorded, and we will be putting the recording online. Once it's online, everybody will get an email with the link to the recording. I also just want to add the video Dr. O'Donnell showed during the webinar didn't really play well for us. For me, I could hear the voices, but the images were delayed. So Dr. O'Donnell, if you could send me the link to that, I can include that when we send out that email, so that everybody can look at it on YouTube.
Yeah.
Okay, and I also just want to add, we have a lot of questions. We're not going to be able to get to all of them, but we will do our best.
I also want to add that I think some of the questions, there's some overlap, so you may get some of the answers that you need from either the presentation or from some of these other questions being answered. So
yeah, Amy, would you do a next question? I'm going to go through the online ones and just answer what I can.
There are some, there are actually a number of questions regarding airway clearance and what are some good ways to loosen up the mucus and get it, you know, maybe to get it to come out better. You know, one question is asking, is it possible for the phlegm in the lower lobes to be compacted, even doing nebulizer treatments? And, you know, somebody else is asking, what are some good ways to loosen the phlegm? So can you talk a little bit about some of the different modalities and other things that might be added?
Sure. So that all falls under the category of airway clearance. So, I always think of it as like simple to more complex. So simple things are like exercise, walking. Then we step it up to using devices like I showed you, that aerobica device or a cappella device, that it's a flutter valve that helps loosen up the mucus and enables you to cough. The next step up in my mind is often to have nebulized saline. So what we call hypertonic or extra salty saline that often that we administer via a nebulizer and help to break up the mucus. And then the next step up kind of is the vest, right? There's several different models of vests that percuss your lungs to help with mucus clearance. So, the basic things are easy to do. If you can walk, if you can huff, cough. I'm sorry that the video didn't come through very well, but there's websites that have examples of ways to do that kind of techniques that you can do for yourself.
Okay. So here's another question about PFTs, and I think this is helpful to discuss it because I think there's a little confusion sometimes about what they show and what they mean. So somebody says they've given some background that they have some mild diffuse bronchiectasis. It's been stable. It's shown some improvement. They have some MAI cultures, and their colony count has improved, but they want to know why their PFT isn't improving and their FEV1 has been going downward.
Yeah, so PFTs often, as opposed to other lung diseases, your PFTs and bronchiectasis don't often change that much, which is a good thing, right? They don't get worse, but they don't get better generally either with, say, treatment of an acute infection. Now also lung function declines normally as we age by, a few hundred or 10 to 100 milliliters of volume as we age. So, and there's the complexity of reading PFTs and interpreting one versus another is also there. So the expectation really is your pulmonary functions are unlikely to change significantly with treatment of exacerbations because of the bronchiectasis being there permanently.
Okay,
I'm
yeah,
gonna
go ahead, Mary, go ahead.
I'm going to jump in with a question because there's a few of these. And Dr. O'Donnell, I know you touched on this in your talk too, but about CT scans. The questions are about how frequently should patients have them? And is there a difference in how frequent they should be if you have bronchiectasis versus NTM?
Yeah, so again, as I tried to say, like it's kind of an individualized thing with the frequency of the scans. In a stable patient, I will do it every 1 to 2 years. In a patient that's more active, there probably will be one in the middle there. I think it's very important not to go like years without a CT because sometimes the disease can progress without much change in symptoms. So even a very, very stable patient, I'm going to get a scan, at least every 3 years, 3 to 5 years. I want to stress that once you're diagnosed with this disease, you should have lifelong care for it. This is something that is, again, the bronchiectasis itself is not going to go away. And so you need lifelong care for this with somebody knowledgeable in it. The second part of the question was about, sorry.
Is there a difference if you have NTM versus bronchiectasis and how frequently?
Yeah, so again, I want to stress that NTM almost always is a complication of bronchiectasis. It's an infection that occurs in bronchiectasis. Now, sometimes we think people can have the NTM infection cause the bronchiectasis, but it's really that vicious cycle. Like most people with NTM have bronchiectasis. It's just that usually it hasn't been diagnosed until the NTM infection occurs. And you really cannot definitively tell MAC infection based on just the CAT scan. You have to have the cultures.
Okay. Mary, do you want me to
Yeah, go ahead and continue.
Question?
Thanks.
So I think somebody else sent in a question. I think it's important to answer this question because this goes back to monitoring. Somebody says, how do I know it's progressing if I feel good and I'm not coughing? I'm breathing fine. There's no mucus. My oximeter is anywhere from 93 to 97 and my breathing is good. I think that's really important to talk about how often we monitor patients with bronchiectasis or NTM infections.
Yeah, so again, it's very individualized. So if you're feeling good and you have a well-established baseline with your physician, and everything is totally fine, you could be seen once a year. But you really have to have that action plan in mind if you do get sick, that you need to call in and try to self-identify an exacerbation. In terms of the scanning, again, I would stretch it out. Patient who's totally fine, that has mild disease to begin with. But I always caution the patients that they really have to, be sure about their follow-up, because it can get worse without you symptomatically changing.
Okay. Mary, do you want me to just keep going through?
Yeah, go ahead for now.
Okay. So somebody has a question about the line probe assay, and I don't know how much you know about this lab testing, but if somebody has MAC that's found on a line probe assay, is that a definitive test for the presence of MAC before the culture comes back?
Yeah, so I'm not the microbiology lab expert, but yes, that is a definitive test. So the way the lab, just very briefly, when they process for MAC, it grows on the plate or in a bottle. Nowadays, it's more in a bottle than on a plate. And then they put a probe on the growth, on the bacterial growth, to identify the organism. So a probe test is the definitive test.
Okay. Here's another good question that I think we get a lot of. MAC versus Pseudomonas. If somebody has both, which is more concerning, and how did the doctors make that determination?
Yeah, I mean, a lot of patients have co-infection with MAC and other routine bacteria like Pseudomonas or other staph. It can be very difficult to tell which bacteria is making the patient sick, if you will. So a lot of times what we'll do is treat the regular bacteria, if you will, the Pseudomonas or the staph first, see how much better the patient gets with, a relatively short course of treatment for that, leave the MAC alone, and then try to make a determination about whether the MAC should ultimately be treated. But it's a very individualized decision based on, patient factors, how the CT looks, and what the cultures are showing.
Okay, and I just wanted to clarify one thing also. To make an NTM diagnosis, it's not done by CT alone. You do have to have those cultures.
Yeah, we can't stress that enough because there's so much confusion out there. Because again, radiology reports, saying it's MAC, when a radiologist cannot diagnose that. You have to have the culture.
Okay. Oh, sorry, Mary, do you want me to take one more, or do you want to go ahead?
Well, yeah, let me just step in for a moment. So we do have a lot of questions about the new bronchiectasis drug.
Brensocatib.
Yes, brensocatib. And so I do want to say that we have had a few webinars that have gone into detail on that. And when I send out the email link to this webinar, I'll include the links to those other webinars so you can get more in-depth information. But I also want to let you know that NTMir and Running on Air are planning on putting a webinar together maybe in August. Right now, the FDA says that they're going to give a decision on August 12th. That's their deadline, which may or may not be met. But we are planning on having a webinar probably shortly after it's been approved, to give some guidance and information to patients, because we know you guys have a lot of questions. So be on the lookout for that webinar that we'll be posting on social media. And if you're in either of our email lists, you'll be getting that too. But Dr. O'Donnell, can you speak briefly about brensocatib?
Yeah,
Or brensocatib? I can never get the name right.
Hopefully they're
Um,
going to pick like a brand name that's easier to pronounce.
Yeah, so yes, I've been involved with the actually, I've been involved with this drug really since the beginning in terms of clinical trials. So there's a positive, what we call phase 2, and then a positive phase 3 study where this drug showed a decrease, the use of this drug showed a decrease in the exacerbation rate of patients who were treated with it versus patients who received placebo. It was about a 20% reduction in exacerbations. So it's not, I mean, I have to say it's not a miracle drug. It's not going to cure bronchiectasis. But based on the data, it's very hopeful that, its ability to reduce exacerbations will be very beneficial for patients. So that's all very positive, I would say. Now the FDA has to approve it. There's a lot of steps that come with that. And then actually, if it is approved, to get it out into the market. So much more to come on that. There's also a trial about to launch in June that many centers will be participating in. That's a similar drug to brensocatib that is going to be looked at in a phase 3 trial.
All right, thank you. Because I wanted to mention that too. Now I do want to say that while it's similar, we're not saying that it's the same, and we're not saying that this will have the same results or be approved by the FDA. But the phase 3 trial is starting up. None of these drugs can be approved by the FDA if patients don't participate in the trials. So I would encourage everybody to, look for a center to participate, see if you qualify, and, participate to help bring these drugs, hopefully to market, to help patients like us.
Great. We have a couple questions about sort of defining bronchiectasis, and I think they kind of go hand in hand and can be sort of answered together. One is asking, is bronchiectasis considered like a category of COPD, chronic obstructive pulmonary disease? And then somebody else has asked about treatments for congenital bronchiectasis, or I guess genetic causes versus the non, the different types, I guess what you call the idiopathic as well.
Yeah, so I'll take that genetic question first because it's very important. I mean, obviously, I mentioned cystic fibrosis, which is the most common genetic reason for bronchiectasis. It's very important to know if you have that or not. And so, although, you think of CF as a disease that obviously you're born with because you are, sometimes it doesn't manifest until later in life. And so testing for CF is important. Because there are treatments that can actually change, fix bronchiectasis that's due to cystic fibrosis. And we're looking to see more trials in primary ciliary dyskinesia and also in the other hereditary disorder, which is alpha-1 antitrypsin deficiency. In terms of the CT scan, really, it is the definitive diagnostic tool that we have for bronchiectasis. I think there was another part to that question, Amy.
Yeah. So, well, they were just asking is COPD, is bronchiectasis considered a part of
so
COPD?
Bronchiectasis technically is a chronic obstructive pulmonary disease, but it is not the same as what we term COPD, because COPD is a smoking related disease. It affects more the large airways, not the small airways, but about 20% of patients with COPD will have bronchiectasis visible on a CT scan. So there's overlap there, but it is not technically bronchiectasis itself is not COPD.
Okay, thank you.
So Dr. O'Donnell, I have a follow-up question in regards to the cystic fibrosis gene, CTFR.
Yes.
Kevin Winthrop and some other doctors published a paper recently, I believe. I was looking for it beforehand, so I don't have it in front of me. But they looked at bronchiectasis patients that had were carriers, I guess, of cystic fibrosis, and found that they had worse outcomes, or could have, more severe bronchiectasis. Are you familiar with that paper?
Yeah, so the issue of being a carrier means you only have one abnormal gene for cystic fibrosis. To have actually the diagnosis of the disease, you need to have two abnormal genes. So it's an area of great controversy right now. Our patients who are carriers, who do not technically have cystic fibrosis, are they at greater risk for developing bronchiectasis? And then there's questions about whether people who are carriers and have some other features that are suggestive of CF, like an abnormal sweat chloride test, whether those patients might benefit from that CF treatment that I mentioned earlier. So, I'd say the bottom line in general for answering the questions about CF is that if you're a patient with bronchiectasis, but you also have sinus disease, or you're infertile, particularly a man with infertility, or you ever had any pancreas problems, you really should be fully tested for CF. But you may see a recommendation evolving on that about testing everybody with bronchiectasis, or nearly everybody, for those genes. So it's really something very much in flux right now. There's no evidence, though, if you have one CFTR mutation that you have worse bronchiectasis. That's not true.
Okay. All right. We have some questions about exacerbations. Somebody's asking, is it typical for exacerbations to last a long time, even being treated with antibiotics, like months and months on end? Can it be like can it last longer than a year?
Yeah, so I mean, typically we think of an exacerbation as one, moment in time. We know that oftentimes the symptoms start, in retrospect, they start much earlier than when the exacerbation is recognized, and that they go on for usually, for many days, not just like, say, the 2 weeks that you're on antibiotics. But no, I wouldn't say that it should last a year. I really think that would prompt looking for other reasons that the patient is not doing well, or for other bacteria that, had not been addressed by the antibiotics that you were given for the exacerbation. So it really is, should be something considered to be like a 30-day thing at most, not a year-long thing. And that would need more investigation.
Okay.
Can you have purulent color sputum and a negative culture?
Yeah, it happens. I love that sputum color chart because I think it gives you a visual that helps you think through that. But it's true, I see it myself because I look at sputums that the patient coughs up when I'm in the exam room with them, and it could be really purulent, and yet the lab turns around and says it's normal respiratory flora. I think that just speaks to the fact that we need better lab techniques. We need, more advanced microbiologic diagnostics, which really are available, but are kind of slowly wending their way into clinical practice. So it isn't uncommon, even though green sputum, you think it's going to be bacterially infected, that it won't have it. And it's probably a lack of technology right now more than a lack of the bugs being there.
Okay. Let me look back at the list. We have some questions about sputum color. Can you go into a little more detail about that? Because somebody's saying that they have cream colored secretions. Their pulmonologist doesn't think they need a bronchoscopy to look at it. Other people want to know, like, what do the different colors indicate? Is there something that they maybe be looking out for in particular?
Yeah, I don't want to overplay the color thing, like I just said, because I think it's a nice guide, but it's obviously just like the CT doesn't tell you what the bacteria is. The color doesn't either. But I would just culture away, like every time, culture weekly, even because it's simple to do if you're not getting an answer. I really have a pretty high threshold myself to take patients to bronchoscopy, just because, most of the time you can just do the culturing from the sputum. But sometimes it's worth, if there's no answer from the sputums after 3 or more tests, it's worth going to a bronchoscopy.
So there's a question here, and it's not for me. Can you give us an update on the new pulmonary rehab unit at Georgetown? And along with that, can you talk about the importance of pulmonary rehab for bronchiectasis and/or NTM? And at what point should patients look into pulmonary rehab?
Yeah, in terms of in general pulmonary rehab, right? It's really a great tool for people to get a supervised exercise program where your vital signs are monitored and you're coached by a pulmonary function tech and an exercise physiologist. Anybody with really abnormal lung function could potentially enroll in pulmonary rehab, but of course it's a resource that's relatively limited. I don't really want to promote my own lab, but it's a new thing. It was given to us partially on the generosity of Grace Ann Dorney and Ted Koppel. And it is accessible for anybody in the city, but we're the only pulmonary rehab program in Washington, D.C. But I would encourage you to talk to your physicians about this, because if it's available in your area and you qualify for it based on having at least, abnormal lung function, it can be a very helpful tool. Now, the caveat is once you're finished the rehab program, which is usually 3 sessions a week for 6 to 8 weeks, you got to keep up the exercising. And that's the tough part, really, to sustain it once you're out of the program.
Okay. We have an interesting question that I think probably relates a little to hemoptysis. We have somebody asking how successful is using, and I'm not sure if I'm saying this right or about the spelling, tranexamic acid.
Yes.
Okay, to treat bleeding lungs. She says she has lung bleeding quite often, but she doesn't think she has an infection. So how successful is that treatment?
Yeah, great question. There's a drug called TXA, or tranexamic acid, which is actually used for bleeding, even like in battlefield situations and stuff like that, bleeding outside the lungs. So there's a couple of studies that have looked at using that as an inhaled therapy in order to quell bleeding. It's kind of we've done it in patients and it does seem to help, but there's not like a 500 patient trial that proves it, or it gives it FDA approval. But that being said, it can be helpful. We often use it more on an acute basis and, like when you're acutely coughing it up, not chronically. So it's something you should talk about with your pulmonologist, because it is available.
Dr. O'Donnell, I want to be cognizant of your time. We're about 15 minutes over.
Yeah, I'm good, especially because my slides were messed up. I feel bad about that. So I'm good for another however long.
Okay, let's go for 15 more minutes because, like I said, I think we've got way more questions, and the questions keep coming in. So we would be here all day otherwise.
Right.
But one of the things that we'll look at doing for the questions that don't get answered is maybe either having a specific webinar that could address them or some other way of addressing questions.
Yeah, we're seeing a lot of questions on things that are specific to how the lab works and microbiology. So we're taking note of those questions, and we're going to start looking at maybe putting together a separate webinar with some speakers who even are working in the lab, and some microbiologists who can sort of speak to that and talk about
Yeah, I
what
think
these
that'd be great.
mean.
Yeah.
Yeah. Okay. All
I
right.
think just one comment there is, all labs are not created equal. And, sometimes we do need to go to more of a specialty lab, especially for non-tuberculous mycobacteria. But this is a very challenging thing that I think, we could talk about for a couple hours. So I would encourage another full session on that.
Yeah, great. Yeah, because there are, as Amy said, quite a few questions in here. An anonymous person put in the question, this presentation is A+++. Thank you very much.
Oh, thanks.
So thank you for that feedback. If you have bronchiectasis but no symptoms or other lung issues, what is recommended? Surveillance with a CT scan yearly? And there was also a question similar asking about doing airway clearance. I think the question said that they were being told not to worry about airway clearance because they were okay right now.
Yeah, I mean, it's very true that there is bronchiectasis being detected on, say you had a cardiac CT. I see that a lot nowadays, right? People are having scans of their heart for calcium scores. And oh, by the way, there's a little bronchiectasis there. That's something that we're going to see more and more as more people get imaging for other reasons. And so there is a large number of patients who have what we would call radiographic bronchiectasis, but really don't have disease. Now, what do we do with those patients? Education is key. That you have it is very important. So that when if you start to have recurrent infections, you will say, hey, doc, I have this bronchiectasis diagnosed a little bit on my scan. You need to know that so that more investigation can be done if you become more symptomatic. In terms of doing airway clearance, if you're completely dry and have like no sputum production, I mean, yeah, I often try to encourage patients to do it, but I get you don't feel like you get any bang for your buck. So then I usually say, well, just walk or just do some deep breathing exercises, and don't worry about doing anything, fancier, if you will, than that. So I generally agree if you give airway clearance a try and you don't produce anything and you're doing well, you don't need to continue it other than to do things like exercising.
Okay.
I have another question lined up if you want me to go, Amy.
Yeah, please go ahead.
So this question, don't steroids suppress the immune system? Isn't the risk benefit of reducing inflammation using steroids not worth the risk of not being to fight MAC or other infections? And I think this would also be a good opportunity to speak to bronchiectasis again in terms of its effect on inflammation.
Yeah, no, great question, because you're absolutely right that we should not routinely use steroids, even inhaled corticosteroids, in patients with bronchiectasis who have chronic infections, because the steroids, even the inhaled ones, right, like your Brio, Advair, those kind of things that have steroids in them, they can actually enhance the infection or increase the infection capability in the lungs. Now, there are some patients, clearly, probably at least 20% of patients with bronchiectasis who do need inhaled steroids because they're kind of wheezy or asthmatic-y. So it's a very individualized decision, but in general, people should avoid inhaled corticosteroids unless they're asthmatic or asthmatic-y. Bronchiectasis is not a steroid. It has nothing to do with steroids. It reduces inflammation in a totally different way by addressing what's the blood cells called neutrophils. So it does not enhance infection at all, as best we know, from the mechanism by how it works, and also from the data from the clinical trials. Completely different.
I think that's actually a very important point that you just brought up that I think needs to be emphasized, is that This, brensocatib it's a novel mechanism. It's a novel compound. It's not an immune suppressive steroid mechanism. And I think there's been some confusion about that. And I think it's very important to point that out. There's these cells that Dr. O'Donnell has mentioned, the neutrophils, that is a specific inflammatory mechanism that's involved in bronchiectasis. And so this drug is very specifically targeting that inflammatory mechanism for treatment.
Yeah, I mean, to get into more where we're going research wise, like I said, there's this Boehringer Ingelheim trial for another similar drug to brensocatib, same mechanism of action. But again, because I want everyone to take home the message that this disease is very different from patient to patient. And even though about 80% of the patients have the type of inflammation that brensocatib addresses, there are 20% at least of patients who have a different kind of inflammation in their lung, more akin to asthma with eosinophils. There's actually going to be trials of those drugs that are already on the market now for asthma biologics for those type of patients. So can't stress enough, how individualized the approach to each patient needs to be.
And actually, again, that I think also merits a follow-up, because you mentioned that there's like a certain subset of patients that this might not apply to, but I also want to point out that there are other disease states where that's also been the case in the past, where they've had a treatment that's only applied to a certain subset of the population. And what's happened is that as therapeutic research has progressed in those areas, and cystic fibrosis is a great example of this. They've started working on treatments for, these other mutations and these other types of, problems with CF. So this is kind of how drug development evolves, is that it starts with one targeted area that they understand. And as we learn more about the disease and the various mechanisms, companies start looking at, okay, what else can we do? How else can we target this, to treat it? So I think that's important, that people don't lose hope and don't say to yourself, well, I don't have that kind of bronchiectasis. It doesn't mean you're never going to get a treatment. It means that this is coming through the pipeline and they're starting to learn more about the disease and about your part of the disease as well.
Yeah, no, I think absolutely important. I mean, spin-offs from these studies are helping us understand the disease. Even the placebo arm of these trials gives us a really good understanding of what's going on that we haven't had before. So as Amy and Mary mentioned, your willingness to be in trials is really, really important to advance this field as well.
Yeah.
Okay, question. You mentioned bleeding as a possible symptom. Could you be chronically bleeding and not be coughing up blood? Perhaps microbleeds?
Yeah, good question. I mean, yes, that's theoretically possible. It's not really the case with bronchiectasis, though. It's usually not microbleeding. That can occur more when people have like an autoimmune disease and they have capillary bleeding rather than bleeding from their bigger blood vessels.
Here's an interesting one. Can you talk about the effects of guaifenesin, which is Mucinex, basically? Under what conditions you would recommend taking it, either episodically or routinely?
Yeah, so guaifenesin, which is like, as Amy said, Mucinex, even Robitussin that's the component. I mean, we don't have any trials looking at the effectiveness of that compound, but for some patients, it's helpful because it does thin the mucus, makes it easier to expectorate. For most patients, it's very safe. And so I tell patients they can try it and see if it helps them. But there's just no, we don't have a phase 2 trial of guaifenesin, just like a lot of like cold medicines that are from the past. Good question though.
What's the difference between a bronchial washing and bronchoscopy?
So bronchoscopy is the overall procedure of putting the scope down into your airways. A bronchial wash or a bronchial lavage is what we do when we have the scope in your lungs. We shoot saline down through the channel of the scope and then suck it back up in order to send it to the lab for cultures. So the bronchoscopy is the overall procedure of putting the scope down, and the wash or the lavage, as we call it, is that obtaining the secretions.
Okay. Oh, here's a really important one, actually, that I think we should mention. Somebody wants to know the difference between high resolution CTs and regular CTs. My doctor only does regular CTs. Are most CT scan machines now doing high res anyway?
Yes, I mean, some radiology offices, you still have to request like a bronchiectasis protocol. Even in our area here in DC, what a high-res scan that helps best detect bronchiectasis is generally that they have some 1 millimeter slices, millimeter, as they slice through the lungs, so very thin slices. But in most radiology practices nowadays, as long as the order is for rule out bronchiectasis, they will do that.
Okay. Thank you. Somebody has a follow-up question on CT scans as well. Once you are negative for MAC, will you still see tree and bud as the appearance? I mean, presumably because the damage, if there's physical damage from an infection like bronchiectasis, that remains and that will continue. That'll still be seen, but if there's a specific tree and bud appearance, does that still remain even after the MAC is gone?
Yeah, no, often we see a phenomenon, what we call waxing and waning tree and buds. Tree and bud is really, like I showed you the picture of the tree with the little buds, is like those buds are mucus stuck in small airways. And so with treatment of MAC, or even with just airway clearance or treatment of Pseudomonas, you'll see improvement in the tree and bud, but often it's like some areas will look better, some will look a little worse. This waxing and waning phenomenon. So yes, you can see it get better, and then see it more in other areas of the lung. It's common.
I just wanted to read a comment out here, and then Mary, maybe you can take the next question, but this comment says, they want us to mention airway clearance techniques, not necessarily along with devices, but any airway clearance techniques are a highly effective way to get mucus out, and it's very important for patients to do. And yes, we are one of the questions that my father, who founded NTMir, he and I have gotten this question very often. What airway clearance is the best airway clearance? Our answer is the best airway clearance is the one you're going to do. You need to do airway clearance. You need to do it every day. And I don't know how many of you attended either online or in person our patient conference recently that was in Berkeley. But we had a patient demonstrate Qigong. And had the whole room standing up and doing it. And she finds it very helpful for airway clearance as well. So really it's a question of like finding, what you want and what works well for you. And it could be a combination of both. We also encourage patients to do exercise, not just for airway clearance, but to help maintain your lung health.
Yeah, I just want to throw in one other idea there too about the importance of good nutrition, and reflux prophylaxis. Like, not everybody, reflux doesn't necessarily make your bronchiectasis worse, but you should really keep that in mind. But good nutrition, maintaining an adequate weight, small frequent meals if you're underweight, really important, along with the airway clearance.
I would also add drinking a lot of water to help those secretions loosen up too. Okay, I think this will be our last question because it's 3:31. Is it okay to do airway clearance in the morning of a PFT or CT scan, or is it best not to do airway clearance prior to these tests?
Yeah, in general, it doesn't make a whole lot of difference. I mean, in our asthmatics, say, that are doing PFTs, we tell them to hold their inhaler for 24 hours. But in bronchiectasis, there's just not that much variability, so I wouldn't fret about that.
Okay. So I'm just going to say we still have 83 questions in the question and answer.
I'm
So
happy to come back and I don't know, I'm sitting
We
in my
tried,
office,
guys.
the internet connection, I'm sorry that there was some kind of lag. I feel bad about that.
oh yeah, that's okay. I mean, I didn't feel like it negatively affected the presentation. And I'm sorry I didn't mention it sooner. Once you sort of adjusted slightly, it worked a lot better.
They slowed down my New York style of talking. All right. Well, thank you, everybody. Really appreciate it.
Thank you
Yeah, well,
very much.
thank you, Dr. O'Donnell. Thank
Mhm.
you so much for doing this talk for us. We will go through the questions because a lot of them, like Amy said, could be a whole nother webinar. So,
Yes.
And will be.
yeah, exactly. So we'll take a look at the questions. You'll get an email from us in a day or two, maybe not with the link to this webinar, but just with some feedback and some of the links that Dr. O'Donnell used in her presentation, and also about how to sign up for studies if you're interested in that. So again, thank you everybody for attending. Thank you, Dr. O'Donnell. Thank you, Amy. And
All right.
hope to see you all on another webinar. Take care.
Great.
Thank
Thank
you.
you. Yep.
Thank you, everyone.